continue with your lesson 8, the serous fluid. So the serous fluid class refers to the fluid circulating found between two membrane linings on our bodily cavity So itong serous fluid na to class, they're usually found in two membranes. Ano yung two membranes na to? These are found in your between your parietal membrane and your visceral membrane. Now, parietal membrane class refers to the membrane that lines the cavity walls. An example of this is the walls of your chest or your chest cavity. While the visceral membrane is the membrane that would cover the organs such as the heart and the lungs. Now, what are the functions of your serous fluids? It serves as a cushion. It acts as a lubricant between the membranes if the body wall and organs to prevent friction, like in the expansion and contraction of lungs. So, cushion siya class. It serves as a cushion. It acts as a lubricant to prevent friction. Now, what are the three major types of serous fluid class? So we have your peritoneal fluid. Peritoneal fluid class is also known as your ascites or ascitic fluid. It is found between the abdominal organs and abdominal cavity. Then we have your pleural fluid. This is found between the lungs and the chest cavity. Then we have your pericardial fluid, heart and chest cavity. So just remember class, if it's plural, lungs and chest. Pericardial, heart and chest. Si peritoneal class, the abdominal organs. Now let's talk about their physiology and composition. Now serous fluid class are maintained by pressure forces and the absorption of fluid in the lymphatic system. So this is somehow similar with your urine class in your nephrons or in your glomerulus. Meron siyang mini-maintain siya class ng hydrostatic and colloidal, also known as your oncotic pressure. So your serous fluid is maintained by hydrostatic and colloidal or oncotic pressure. Now within the parietal and visceral membranes, these are blood vessels and these membranes are lined by mesothelial cells. So, di ba class yung serous fluid nyo is the fluid found between parietal and visceral membrane. Now, itong membranes na to, yung lining ng membranes nila, they are lined by cells known as your mesothelial cells. Now, what are these mesothelial cells? It serves as a non-selective filter for the blood, allowing entry of small substances but prohibits large substances. So, if we try to compare this class with your CSF, di ba sa CSF nyo merong choroid plexus? The choroid plexus, surrounding the choroid plexus or yung blood-brain barrier nyo, di ba? It's also a non-selective filter. The blood-brain barrier, the cells surrounding it also prevents the entry of small substances, of large substances. So yung mesothelial nyo is the one responsible for filtering your serous fluid. Now, serous fluid is formed as an ultrafiltrate of the plasma. May have the same chemical components as blood. No chemicals or substances are added by the mesothelial cells. The accumulation of excess serous fluid is known as effusion. So if there's too much serous fluid class, too much pleural fluid, too much peritoneal, too much pericardial fluid, you would have what we call an effusion. It results from the disruption of two maintaining forces. So kung na-disrupt, if your hydrostatic pressure is affected or your colloidal or oncotic pressure is affected, it would cause an effusion. Now, what are the different causes of effusion class? We have your congestive heart failure. If you have congestive heart failure, you would have increased hydrostatic pressure. If you're suffering from hypoproteinemia or low blood protein or decreased proteins in the plasma, this would lead to decrease in oncotic pressure. If you're suffering from inflammation or an infection, there would be increased permeability of blood vessels. And if you have tumors, such as which would cause lymphatic obstruction, this would also increase permeability of blood vessel due to membrane damage. So if there's an increased permeability, there would be increase in serous fluid, causing an effusion. Now, what are the two types of effusion class? We have what we call a transudate and an exudate. So if you have too much, again, class I, if you have too much serous fluid, you have an effusion. Now, effusion is divided into two types, a transudate and an exudate. Now, let's tackle them. Let's tackle their difference, class. A transudate class results from the disruption in the balance of regulation of fluid through filtration and reabsorption between the serous membrane. Usually, the fluid would appear clear and colorless. The problem is in the hydrostatic and oncotic pressure. There would be an increase in hydrostatic pressure, decrease in oncotic pressure. Now, what are the diseases that lead to this type of effusion or transudate effusion? We have your congestive heart failure, increased hydrostatic pressure. We have your liver cirrhosis, decreased oncotic pressure. Then we have your nephrotic syndrome, which would also cause decreased oncotic pressure. Then let's talk about your exudate. Now, exudate naman class is produced by conditions that damage the membrane of bodily cavities. So just a recap class, kapag transudate, the problem is between the two pressures, the hydrostatic and oncotic pressure. It could be an increase in hydrostatic or a decrease in oncotic. But if it's an exudate class, there is a problem or there is a damage to the membranes of the body cavity. There would be an increased permeability of the parietal and visceral membrane. So the problem here naman class is the parietal and the visceral membrane. There is an increased permeability. It exhibits various colors and is cloudy in appearance. So if it's a transudate class, clear and colorless, but if it's an exudate, it would have different colors and would be cloudy and in appearance. Most common causes would be infections, inflammation such as autoimmune disorders, lupus and rheumatoid arthritis, and even malignancies. So I hope you were able to understand, class, the difference between a transudate and an exudate. So if it's causes, transudate is caused by a problem in the pressure. Kapag exudate, it's problem with the membranes, the parietal and the visceral. Ang appearance, class, ng transudate nyo is usually clear and colorless. Kapag exudate naman siya, class, different colors and cloudy in appearance. Now, these are the laboratory tests to differentiate exudate from a transudate. So again, class, if it's a transudate, the appearance would be clear. For an exudate, it would be cloudy. Now, in any body fluid class, there would be different substances. There would be proteins, there would be enzymes, and so on. Now, for you to differentiate if it's a transudate, you would have to check there's fluid to serum ratio. When I say fluid to serum ratio, it could be your pleural fluid to serum protein ratio. It could be your peritoneal or your pericardial. So if you want to test, if you want to know if the pleural fluid is a transudate or an exudate effusion, you need to do this. Or if you want to know if it's a peritoneal transudate or exudate, you need to test for this. Now, those that are in red class are the most important tests that would be done. So if the fluid to serum protein ratio is less than 0.5, it's a transudate. If greater than or equal to 0.5 class, it's an exudate. If the fluid to serum LD ratio, lactate dehydrogenase ratio, is less than 0.6, it's a transudate. If greater than or equal to 0.6, it's an exudate. If fluid to serum bilirubin ratio is less than 0.6, it's a transudate. If it's greater than or equal to 0.6, it's an exudate. Then you have your fluid serum cholesterol ratio. If it's less than 0.3, it's a transudate. If greater than or equal to 0.3, it's an exudate. Then for the WBC count, if it's less than 1,000 per UL, it's a transudate. If it's an exudate, it would be greater than 1,000 per UL. Spontaneous clotting class. So there would be no clotting if it's a transudate. If it's an exudate class, there is a possibility of clotting. If it's then we have your pleural fluid cholesterol. If it's less than 45 to 60 milligram per DL, it's a transudate. If greater than 45 to 60 milligram per DL, it's an exudate. Then serum ascites, albumin gradient. If it's greater than or equal to 1.1, it's a transudate. Exudate less than 1.1. So do memorize this class, this table. They will come out in your quiz. Now, how do you collect your serous fluid class? So you would usually collect this through the needle aspiration from their respective cavity. So if you want to collect pleural fluid class, you would collect it in the lungs for pericardial in the heart and peritoneal in the abdomen. So needle is injected into the cavity and aspirate, and you would aspirate, or the doctor would aspirate at least 100 ml of fluid. So if it's pleural fluid class, the procedure is known as your thoracentesis. For pericardial fluid, it's the procedure is known as your pericardiocentesis. If it's your peritoneal fluid in the abdomen, it's known as your paracentesis. Now, for cell count and differential count, you need to collect fluid in the EDTA tube. So if you want to do cell count, diff count sa hematology, EDTA. For microbio and cytology studies, collect fluid in a heparinized tube. For chemistry tests, heparinized tubes are also used. Clotted fluid in plain tubes can also be used. Fluids for pH testing are kept anaerobically in ice class, meaning they are not allowed to be exposed to air. So dapat yung tube nyo class is tightly closed. Then pleural fluid is collected. So for every fluid class, you would be collecting 3 tubes, and there is an order of draw. And for every tube, for every order of draw, there is a required test. So for pleural fluid class, you would collect 3 tubes. The first tube is for culture and gram stain, while the remaining 2 tubes, 2 and 3 class, could be used for cell count, right stain, total protein, glucose, cytology, and others as requested. Then for pericardial tubes class, the tube is used for gross and microscopic examination. Plain tube class is used for microbiological studies, and heparinized tube would be for chemical analysis. Then for peritoneal fluid class, you would also collect 3 tubes. EDTA is similar siya with pericardial class. EDTA is used for gross and microscopic. Heparinized is used for both microbiological and chemical analysis. Then take note of the amount aspirated. So kapag plural, it's usually 10 to 20 ml. Pag pericardial, 10 to 50 ml. And peritoneal would be 5 to 20 ml. But in some cases, class, it could reach up to 50 ml in ovulating women. Now, let's first tackle your pleural fluid. In the pleural fluid, we have your physical analysis. So, appearance class. If its normal appearance is clear, pale yellow. If your pleural fluid appears turbid or white class, there's a microbial infection. If it appears bloody, there could be a hemothorax, a hemorrhagic effusion, a pulmonary emboli, tuberculosis, or a malignancy. Then if it's milky class, it could be a thoracic duct leakage, chronic inflammation. If it's brown naman class, there would be a rupture of amoebic liver abscess. So familiar kayo class, di ba, sa entamoeba species, in some advanced cases of your amoebiasis, it would travel to the liver, causing abscess there. Then black appearance of pleural fluid class is usually a fungal infection, aspergillus, which would infect the lungs. So kapag black yung pleural fluid mo class, yung patient niya has an aspergillus infection. Then if it appears viscous, there is a malignant mesothelioma. So may cancer yung patient niya. Now, these are some examples class of your pleural fluid. So, the first one, yung letter A dyan, this is a blood-stained pleural aspirate. This patient had pleural metastasis from carcinoma of the breast. So, may cancer siya sa breast class, causing a blood-stained pleural fluid. Then, yung B naman, yung nasa gitna, this is a chylous pleural fluid. This patient had bronchial carcinoma that had invaded and obstructed the thoracic duct. Then the last one is a pleural transudate. So pleural transudate siya class. This pale effusion is typically found in patients with heart failure or other causes of generalized edema. Now, in pleural fluid class, there are two things you need to take note. You need to learn how to differentiate a hemothorax from a hemorrhagic effusion. Now, in hemothorax and hemorrhagic effusion, what you need to identify first is the patient's blood hematocrit and pleural fluid hematocrit. So, if the pleural fluid hematocrit class is more than 50% of the whole blood hematocrit, then the bloody appearance is caused by hemothorax. So let me repeat class, if the pleural fluid is more than 50% of the blood hematocrit. So let's say ang whole blood hematocrit ng patient nyo is 0.50, 0.50 class. So if we take the 50% of 0.50, 50% of 0.50 is 0.25. If the pleural fluid hematocrit class is around, let's say, 0.30. 0.30 class is greater than 50% of your blood hematocrit. Therefore, this is a hemothorax. Now, hemothorax could be caused by an accident, a recent surgery, traumatic injury, getting beat up real bad. Now, if your pleural fluid naman class is less than 50% of the whole blood hematocrit, then the bloody appearance is caused by hemorrhagic effusion, seen in infection or inflammation of the pleural lining caused by increased permeability. So let's say class again, the blood hematocrit of the patient is 0.50. So you get the 50% of 0.50, it's 0.25. And when you tested the pleural fluid hematocrit that is bloody, you got a hematocrit of 0.20. Since this is less than 50% of your blood hematocrit, then this is a hemorrhagic effusion caused again by an infection or inflammation. So I hope that was clear. Now let's talk about the another thing to consider. Pleural fluid that is chylous versus pseudochylous effusions. When you say pseudochylous, these are false or not true chylous effusions. So if it's a chylous effusion class, it is caused by thoracic duct leakage seen in surgery or trauma. But if it's a pseudochylous effusion, seen in chronic inflammation. If it's a chylous effusion class, the appearance would be milky or white. If it's a pseudochylous infusion, it's usually milky or green tinge. Now, if it's leukocytes class, in a chylous effusion, the predominant leukocyte is lymphocyte. But if it's pseudochylous, there would be mixed cells. Then, if it's a chylous effusion, there would be absence of cholesterol crystals. Pseudochylous effusion, presence of cholesterol crystals. If it's a chylous effusion, triglycerides would be greater than 110 milligram per dl. If it's a pseudochylous effusion, less than 50 milligram per dl. If it's a chylous effusion class, chylomicrons would be present. So there would be a creamy top layer. If it's a pseudochylous effusion, there would be no chylomicrons. Sudan 3 staining, so strongly positive in chylous effusion, so, and negative or weakly positive in a pseudochylous effusion. Now, chylous effusions class would contain triglycerides, while pseudochylous would contain cholesterol. So do remember that class. Chylous, triglycerides, pseudochylous, cholesterol. So Dan 3 would only stain triglycerides and not cholesterol. So this is an example class of a chylous pleural fluid. Milky white appearance. Now let's go to the microscopic examination. So what you would normally see in a pleural fluid class is that macrophages would account for the majority, usually 64% to 80% of total WBC, followed by lymphocyte 18 to 30%, and neutrophils 1 to 2%. Now, if there is an increased neutrophil, let's say greater than 50% neutrophils are seen, it's a sign that the patient has pneumonia, pancreatitis, pulmonary infection. If there is an increased lymphocyte greater than 50%, it could be TB, viral infection, autoimmune, or malignancy. If it's increased eosinophil greater than 10% class, it could be a trauma. So it's either pneumothorax or hemothorax, allergic reaction, or parasitic infection. Now, the defining cell class in your pleural fluid is a mesothelial cell. Ano ba tong mesothelial cell na to? Again, your mesothelial cells are the ones lining the two cavities. This is normally found in pleural fluid. It lines the parietal and the visceral membrane. And there are two types of mesothelial cell, the normal and the reactive mesothelial cell. So for you to differentiate them, take note of the characteristic. Kapag normal, if it's a normal mesothelial cell, it would have a fried egg appearance, dark blue cytoplasm, and a round nuclei. If it's a reactive mesothelial cell class, it has a varying amount of cytoplasm, an eccentric nucleus, and usually multinucleated. So if you have an increased reactive mesothelial cell, you can either have a pneumonia or worst case, you have cancer or malignancy. And if you have decreased reactive mesothelial cell or decreased mesothelial cell, meron kang tuberculosis. So usually class kapag may TB ka, all you would see in your pleural fluid are neutrophils. Naka-encounter na ako sa work ko class, yung pleural fluid niya is all pus, puro nana, because the patient is suffering from tuberculosis. So 100%, 100% neutrophils ang kanyang diff count. Then another cell class is plasma cells. Plasma cells may be increased in tuberculosis. Now, you would also be able to see malignant cells. This is a primary concern in examining all effusions to detect malignant cells. So, ang characteristic class 1 characteristics of a malignant cell is that it would have nuclear and cytoplasmic irregularity, hyperchromatic nuclei, cellular clumps with cytoplasmic molding, appearing as community borders. It also has an abnormal nucleus cytoplasm ratio. There would be adenocarcinoma, seen in adenocarcinoma, small cell carcinoma, metastatic carcinoma. Normal forms of mesothelial cells class would often resemble lymphocytes, while reactive mesothelial cells would look like malignant cells. Let's go to the chemical examination. So the most common tests performed in pleural fluid class are pH, glucose, adenosine deaminase, and amylase determination. So glucose class, if less than 60 milligram per dl, it's considered decrease. Decreased amount is seen in rheumatoid inflammation and purulent infection. You need to do a blood comparison. When you say blood comparison class, you have to compare your pleural fluid glucose with your plasma glucose. Then lactate class, increase in bacterial infection. Triglyceride naman class, seen increase in chylous effusion. Then we have your pH. So less than 6, acidic yan class, indicates esophageal rupture. Esophageal rupture class would allow influx or cause leakage of gastric fluid going to the pleural membrane. Then if it's less than 7.3, it could indicate a urinothorax. Urinothorax class is the presence of urine in the pleural cavity due to retroperitoneal leakage of urine in the pleural space. Also decrease in pneumonia cases that are not responding to antibiotics and esophageal rupture. Then we have yung walang kamatayang ADA class. So familiar na kayo dito. Increase in TB and malignancy. Then amylase naman class, seen in increase in pancreatitis, esophageal rupture, and malignancy. Then we have the microbio and serology tests. So gram stains with aerobic and anaerobic cultures of acid fast stain. So mga TB class and special culture techniques, mycobacterium culture. Detect the presence of microorganisms primarily associated with pleural effusions, such as Staph aureus, Enterobacteriaceae, anaerobes, and MTB, which would cause your pulmonary TB. So we're done with your pleural fluid. Now let's go to your pericardial fluid. Let's first tackle its physical analysis. So it would usually have a maximum volume of 50 ml only. The normal appearance of your pericardial fluid is clear, pale yellow. So it would be a transudate. If it's turbid class, this is an effusion resulting from infection and malignancy. If it's blood streak, it could also be seen in malignancy and infection. If it's grossly bloody, it could be a cardiac puncture, anticoagulant medication, or overdose. If it's milky, chylous, or pseudochylous effusion, normal amount class is 10 to 50. So maximum na yung 50 ml ng pericardial fluid. Increased fluid is usually due to transudate or exudate. Best test to differentiate transudate and exudate in the pericardial fluid class is your fluid serum protein ratio and fluid serum lactate dehydrogenase ratio. So yan yung best test class to differentiate transudate and exudate in pericardial fluid. The fluid to serum protein ratio and the fluid to serum lactate dehydrogenase ratio. So to do this class, determine if the excess pericardial obtained is transudate or exudate. So you would get the pericardial fluid total protein and the serum total protein. So ang gagawin nyo lang class, you would divide the pericardial fluid total protein over the serum total protein. So this is one way to get to identify if it's a transudate or exudate. So let's say class in this example, ang total protein ng pericardial fluid nyo is 4 and the serum total protein of the patient is 8.76. So 4 divided by 8.76, you would get 0.45. So if it's less than 0.5 class, again, it's a transudate. Less than 0.5 transudate. Greater than or equal to 0.5 class, it's an exudate. Now, other significant tests. So, pericardial fluid testing is done to determine if it's a transudate or exudate. Malignancy is usually detected by means of cytological testing. Endocarditis is confirmed through microbiological tests. So, if it's greater than 1,000 WBCs and increased neutrophil, this could be a sign of bacterial endocarditis, the major cause of exudate, confirmed by positive gram stain and culture. Major cause of this bacterial endocarditis class are your strep and staphylococcus bacteria, even adenovirus and Coxsackie virus. Then malignant cells could be a sign of metastatic carcinoma, detection of CEA or your carcinoembryonic antigen is also for metastatic carcinoma. Increased adenosine deaminase and acid fast staining, tuberculosis or tubercular effusion. Effusions of tubercular origin are increased as a result of AIDS. So, do memorize this table class. Hindi ko na siya i-discuss kasi yan din naman yung kanina. Do memorize this table. It will come out in your quiz. Now, let's go to the last fluid class, the peritoneal fluid, the physical analysis. So, common reasons for increased ascetic fluid. Diba, another name for peritoneal fluid is ascites or ascetic fluid. This could be due to hepatic cirrhosis or peritonitis. So if it's a transudate class, transudate na peritoneal fluid, it would be a hepatic origin, usually in cirrhosis. If it's a peritoneal effusion that is an exudate, bacterial peritonitis from intestinal perforation, ruptured appendix, and even malignancy. So the most recommended way to differentiate transudate from exudate class in peritoneal fluid is the serum ascite albumin gradient or yung SAAG nyo. So what you would do here class is you would get the fluid albumin, your peritoneal fluid albumin, and subtract it from serum albumin. So serum albumin minus peritoneal fluid albumin. If it's greater than 1.1, it's a transudate. If it's less than 1.1, it's an exudate. So this is the physical appearance class. Normal appearance ng peritoneal nyo is clear, pale yellow. If again it's turbid, usually microbial infection. If it's green class, there's a gallbladder disorder. The reason kaya siya green class, di ba, in your gallbladder, there's the substance known as your bile. So bile would mix with your peritoneal fluid, causing a green peritoneal fluid class. Also seen in pancreatic disorder. Blood streak seen in trauma, infection, malignancy. Milky, lymphatic obstruction, malignancy. Then cellular examination, WBC count, normal if less than 350 cells per UL. Absolute neutrophil count should be greater than 50% of total WBC count or greater than 250 cells. Indicates infection like peritonitis. Lymphocytes would be elevated in TB. Then we have your cells in the peritoneal fluid. So you would find WBC, mesothelial cells, macrophages, also known or specifically the lipophages. So kapag lipophages siya, these are macrophages that have ingested lipids. In some cases, pathogens can be seen like fungi and parasite, yeast cells also. Then you would also see malignant cells. They would appear multinucleated, irregular cytoplasm nucleus ratio, most often would contain mucin vacuoles. They vary in size, two or more nuclei, usually from prostate, gastrointestinal, and ovarian origin. Carcinoma metastasized, that's why it can be seen in peritoneal fluid. And a known cell class in peritoneal, siya yung katangi-tangi is known as your Samoma bodies. So Samoma bodies are concentric striations of collagen-like material seen in benign cancer of thyroid and ovaries. So don't forget the Samoma bodies in your peritoneal seen in benign cancer of thyroid and ovaries. Other significant test class. So total WBC, if less than 500 cells per UL, normal. Greater than 500 cells, bacterial peritonitis and even cirrhosis. So chemical test class for glucose. Glucose would be decreased in tubercular peritonitis malignancy. Amylase produced in the pancreas, increase in pancreatitis, GI perforation. Alkaline phosphatase, increase in gastrointestinal perforation. BUN and creatinine, increase in ruptured or punctured urinary bladder due to contamination of urine. Then microbiology tests, gram stain, and aerobic and anaerobic culture. Aerobic cultures class, you need to inoculate blood culture bottle at bedside. For acid fast smear, we have your adenosine deaminase and culture for TB. Adenosine deaminase increase in tubercular peritonitis. So that ends your serous fluid class. So do memorize the tables. Thank you.